All right, welcome to the hot seat. If you're gearing up for an advanced medical oral exam, you are exactly where you need to be. Think of this as your high-yield explainer. Okay, let's dive into this. We're going to trace the fascinating and, honestly, sometimes chaotic journey of a drug right through the human body. We'll be focusing squarely on the foundations of pharmacokinetics and hepatic metabolism, going after exactly what those examiners are waiting to hear.
Look, the very first thing examiners are going to want to hear is a crystal clear distinction between pharmacokinetics and pharmacodynamics. Pharmacokinetics, that is entirely about what the body does to the drug. And this isn't just academic theory, right? It's a vital clinical tool. We're using this to predict plasma concentrations, dial in the right dose, set the interval, and ultimately keep our patients safe from toxicity. It is literally the physiological gauntlet that every drug has to survive.
Okay, here's our mental syllabus for the next few minutes. 1. The ADME framework. 2. Volume of distribution. 3. First versus zero-order kinetics. And then we'll wrap up with 2 heavy-hitting clinical cases, paracetamol toxicity and morphine and renal failure.
Starting off with Section 1, the ADME framework. Every single drug's journey starts by navigating absorption, distribution, metabolism, and excretion. That first hurdle, absorption, introduces the concept of bioavailability, or F. It's simply the fraction of the dose that actually makes it into systemic circulation unchanged. So the crucial point is, giving a drug IV guarantees you 100% bioavailability every time. But swallowing a pill, man, that is a totally different story. An oral drug just gets battered. The actual functional dose drops way down before it ever sees the bloodstream because of incomplete absorption, GI tract degradation, and of course that dreaded first-pass metabolism in the gut wall and the liver. And this sets up a classic professor question. Why do we shoot insulin instead of swallowing it? Well, small molecules can usually survive that oral gauntlet, but large proteins and peptides like insulin? No way. To your GI tract, that life-saving insulin is just a delicious steak. Your digestive enzymes are going to chop it up into useless little fragments long before it can do its job. It's the ultimate barrier of GI degradation, and it's exactly why parenteral administration is strictly mandatory for drugs like that.
Moving on to Section 2, volume of distribution. Okay, so once a drug finally makes it into the blood, it doesn't just hang out there. We enter the distribution phase. Let's put you right in the exam spotlight with a high-stakes scenario. You're in a clinical emergency. Say you need to acutely stop status epilepticus, or maybe you're treating a lethal arrhythmia. In that moment, do you want to reach for a drug with a large volume of distribution or a small one?
To answer, emphatically, is a small VD. Think of a small VD like a shallow puddle. It traps the drug mostly within the vascular compartment, and because it's concentrated right there in the blood, it rapidly hits high plasma levels and immediately gets to those highly perfused target organs, like the brain or the heart, without you having to push a massive, slow-loading dose. On the flip side, a large VD acts like a deep, hidden well. The drug just sequesters deep into peripheral tissues like fat and muscle, literally hiding away when you desperately need it circulating in the bloodstream.
Let's hit Section 3, first versus zero-order kinetics.
Now, we're stepping into some real mathematical danger as the body tries to clear the drug. You absolutely have to nail this distinction. Most drugs follow first-order elimination, meaning a constant fraction of the drug is cleared over time, directly proportional to whatever is in the plasma. But the real danger is zero-order elimination. This kicks in when the body's elimination pathways are completely maxed out, saturated. Suddenly, only a constant amount is cleared over time, no matter how much drug is floating in the plasma. It's exactly like a saturated toll booth where traffic is violently backing up. Because clearance is hard capped at that toll booth, even a tiny bump in the dose causes massive, disproportionate, and incredibly dangerous spikes in plasma concentration.
And listen, examiners absolutely love testing the exceptions, the drugs that dangerously shift into this zero-order territory. Phenytoin is the classic one, but another huge one is aspirin. Usually aspirin is hydrolyzed to salicate and conjugated safely in the liver. But if someone takes a toxic, high dose, those conjugation pathways just completely saturate. The elimination violently shifts from safe first order right into that saturated zero-order traffic jam. The result is rapid drug accumulation, tinnitus, and some really severe acid-base disturbances.
Which brings us to Section 4, paracetamol toxicity and COX-3. Let's zoom right into the liver for a second, the hepatic crucible. Let's move through this and see how a simple overdose builds step by step into a total crisis. Normally, paracetamol is metabolized safely, but in a massive overdose, say over 10 grams, those safe pathways are fully saturated. So the drug gets forced down the cytochrome P450 pathway instead, and that forms a highly reactive, incredibly toxic metabolite called NAPQ. Usually, your liver has glutathione to easily neutralize NAPQ, but in an overdose, those glutathione stores are totally wiped out. So this unneutralized NAPQ binds directly to liver cells, triggering fatal hepatocellular necrosis. The life-saving antidote here is N-acetylcysteine, or NAC. Giving NAC essentially provides the precursor your body needs to rebuild those hepatic glutathione stores and mop up all that toxic NAPQ.
And hey, while we're talking about paracetamol, we've got to clear up a very common trap. If the examiners bring up COX-3, you need to know that modern molecular research is definitive on this. A functional, distinct COX-3 enzyme does not exist in humans. Period. Paracetamol actually works via weak, state-dependent inhibition of human COX-2 and acts as an indirect endocannabinoid modulator. So when that comes up, debunk the COX-3 myth with absolute authority.
All right, final section. Section 5, morphine and renal failure.
So, unlike a lot of drugs, morphine completely skips phase 1 functionalization in the liver. It jumps straight into phase 2 conjugation. Now, what's really interesting about this is how just one single hepatic enzyme, UGT2B7, creates two totally different and potentially lethal traps. Morphine undergoes glucuronidation to make two main metabolites. The major one is M3G, making up about 60%. It's totally inactive at opioid receptors, but it's a neurotoxin. It causes neuroinflammation and hyperalgesia. Then you have the minor metabolite M6G. That's only about 10%, but it is highly active. We're talking an extremely potent analgesic, actually way more potent than morphine itself.
This dynamic creates a massive clinical mandate. Both M3G and M6G are cleared by the kidneys, so if your patient has kidney impairment, these metabolites don't magically disappear. They accumulate rapidly right in the bloodstream. That M3G is going to cause severe localized neurotoxicity, and that M6G, it's going to cause prolonged, potentially lethal respiratory depression and coma. And that is exactly why morphine doses absolutely must be drastically reduced or just entirely avoided in patients with kidney impairment.
And this brilliantly illustrates our ultimate goal here. Ask yourself, are you just memorizing pharmacokinetic equations to pass the test? Or are you truly mastering the journey of a drug so you can safely manage the absolute chaos of human physiology? Really grasping the ADME framework, volume of distribution, zero-order kinetics, and these hepatic pathways. It's not just about surviving an oral exam, it is about predicting toxicity and literally saving lives in clinical practice. Keep these frameworks locked in the front of your mind, and you are absolutely going to own that hot seat.